Hi guys, and welcome to another very high yield USMLE video. Today we're going to discuss the deep venous thrombosis and pulmonary embolism. So let's get started. The deep venous thrombosis and pulmonary embolism are two manifestations of venous thromboembolism VTE. Now, what does VTE describe? It describes when a clot is formed somewhere in the legs, in the groin, or even in the arms. Then this clot travels with the circulation to reach the lungs. Then it lodges somewhere in the lungs and causes pulmonary embolism. Now, as you can see here on this slide, we will be discussing the Virchow's triad, named after the father of modern pathology, Rudolf Virchow. Now, this triad describes the three main categories of factors that lead to DVT. First is hypercoagulability, second hemodynamic changes, and third are vascular endothelial injuries. Let's discuss now first the hypercoagulability. As you can see here, we have congenital hypercoagulable states and acquired hypercoagulable states. Now let's discuss first the congenital ones. And we're going to start with the factor 5 of Leiden mutation. Now here this mutation is named after a city in Netherlands, by the way, and you can pronounce it as Leiden or Leiden as you wish. But here the problem is this is a blood clotting disorder where we have mutated factor 5 from our coagulation cascade. And we're gonna see thrombophilia in the veins. Now, normally what happens is the activated protein C inhibits factor 5, which ultimately leads to slowing down of the coagulation cascade. But now if our factor 5 is mutated, then it cannot be inactivated by your protein C. So the coagulation cascade will keep going and going and going and making more and more clots. Now here the factor 5 of Leiden mutation is autosomal dominant condition with incomplete penetrance and is seen most commonly in Caucasian European people less than 45 years of age. Now protein S and protein C, as we said, they normally turn off the coagulation cascade. Protein C gets activated by protein S to inhibit factor 8 and factor 5. In the antithrombin 3 deficiency, we're gonna observe again hypercoagulability because antithrombin 3 normally inhibits factor 10 and factor 2. In the prothrombin G2021A mutation, basically here the problem is that they make too much of prothrombin protein, which literally translates into more clots formation. In the acquired hypercoagulable states, we have the antiphospholipid syndrome, the heparin-induced thrombocytopenia, which, as you know, the most common heparin that causes HIT is the unfractionated heparin. And in HIT we see decreased platelets, venous thromboembolisms, and also pulmonary embolisms. And we all know what is the problem here. We have an antibody against the platelet factor 4 surface protein, which has attached heparin to it. Other causes for the acquired hypercoagulable states are cancer, pregnancy, nephrotic syndrome, as you lose the antithrombin 3 when you have nephrotic syndrome and your kidneys are not working properly, OCPUs. Now, hemodynamic changes basically is to say abnormal blood flow. It can be either slow or absent, or it can be too fast, known as turbulent blood flow. And we can see these hemodynamic changes in congestive heart failure, immobility, or recent surgery. And the last of the Virchow's triad is the vascular endothelial injury, which can be caused again by trauma or surgery or recent fracture. Before we move on to the signs and symptoms of DVT and PE, let's discuss these two things here so we don't confuse them with DVT, because it's very easy to confuse them. Now, the superficial vein thrombosis is not deep vein thrombosis, as you can see by the name. Now, superficial vein thrombosis can be caused by both inherited and acquired thrombophilic states, and it can progress to DVT and PE, but it's not DVT per se. Alright, and also varicose veins. Varicose veins are also not deep venous thrombosis. Varicose veins means that the veins in the legs are enlarged, twisted, bluish in color because they carry deoxygenated blood. Now, if this is a vein, the veins have one-wave valves in them. So this valve helps the blood to travel in one direction only. And this direction is from your legs to your heart. Alright? From your legs to... Okay, so if this is the heart, the blood has to flow from your legs, from the peripheral part of your body to your heart, then through your lungs so it can get oxygenated and then travels back to the rest of the body. Now, the two most common times when you see varicose veins is when the person is aged, a little older, and during pregnancy. Now, why is this happening? Now, as we grow old, the elasticity of the vein wall decreases, right? So if the vein was nice and elastic here when you're young, when we grow old, if it loses the elasticity, it's going to enlarge, right? It's gonna lose this beautiful shape here. Now, as the vein enlarges, what do you think is going to happen with this valve? Do you think the valve can suddenly grow more? No. So the valve here will not be able to close this opening here. So the blood, due to the gravitational pull, will start moving downwards towards your feet. So instead of going upwards towards your heart, due to the gravitational pull and because the valve cannot close properly because the vein has lost its elasticity, the blood will start going downwards because of the gravitational pull, and that's why you're going to see varicose veins. Another very common cause for the development of varicose veins is pregnancy. As we all know, during pregnancy the blood volume increases, right? But the blood flow from your legs towards your heart decreases because there is an obstacle, there is a belly growing, which doesn't allow the blood from your legs to flow freely from your legs to your heart, right? And as the back pressure increases because your belly is growing, this blood will start pushing down. It's going to open the valves, the vein valves, and it's going to start pulling in your veins in your legs. Okay, moving on to signs and symptoms of DVT and PE. Now remember that the signs and symptoms for both DVT and PE are non-specific. That's why we have Wells criteria for DVT and PE, so we can diagnose them better. Otherwise, the signs and symptoms, remember, are non-specific. Now for DVT, these signs include extremity pain, edema, swelling, erythema, and also here I want you to remember what is distal DVT and what is proximal DVT. Now the distal DVT are basically clots in the CAVA veins, and the CAVA veins are the peroneal, the anterior and the posterior tibial veins, and the muscular veins. And what is proximal DVT? Basically it's a clot in the following veins: in the popliteal veins, femoral veins, and iliac veins. The signs and symptoms for pulmonary embolism are again non-specific. The patient can present with shortness of breath, chest pain, non-productive cough, hemoptysis, sinus tachycardia, and even fever. Now, when a patient presents with these symptoms, what is your next step? Chest X-ray, right? And on chest X-ray, what do you expect to see? Well, this is the tricky part, that on chest X-ray you will see absolutely nothing. The chest X-ray will be normal and the patient will have equal bilateral breath sounds. Alright, so you cannot diagnose the patient like this, right? So what are you going to do next? Yes, you're right, you're going to do an EKG. Why? Because you're looking for a right heart strain. Now, why are you looking for a right heart strain? Now, if I can draw here real quick the heart, if this is your heart, and this is your right ventricle, right atrium, right ventricle, left atrium, and left ventricle, the heart from your right atrium goes to the right ventricle and then through the pulmonary artery, which looks something like this, it will go to the lungs, right? So let's draw the lungs here. Really schematic drawing I'm making? Alright. So the blood from the right ventricle has to go through the pulmonary artery and then goes to the lungs, right, to get oxygenated. Now imagine here in the lungs you have a clot or many clots, you don't know. Imagine you have, let's say, several clots, right? What do you think is going to happen with the pressure in your pulmonary artery? It's going to increase, right? Because you cannot push the blood through the clots. So the clots are obstructing here, so the blood that is coming from the right ventricle through your pulmonary artery cannot reach the lungs, the end of the periphery of the lungs. So here the pressure will increase and the back pressure will continue building, which will lead to right ventricle and overall right heart strain, because the blood which ends up backwards in the right ventricle is going to go to the right atrium and again towards the periphery. So you get the point, right? So here on EKG, this is what you're looking for a right heart strain. And the most common finding you will see is non-specific ST T-wave changes. Now I know that you have heard about the S1 Q3 T3 phenomenon on EKG, which is basically S wave in lead 1 and Q wave in lead 3 and inverted T wave in lead 3, but this is not the most common presentation. Alright, forget about this. They're gonna test you, and in real life you're going to see non-specific ST T wave changes. Now if your patient presents with these symptoms, but on top of that his blood pressure is very low, or he's even in shock, then when you perform the chest x-ray you will see a big, massive or submassive pulmonary embolism, and on chest x-ray you will see a wedge infarct in the lung. So this is going to be very easy to diagnose. And how to manage these patients in real life settings, and when you start your residency in internal medicine, you can see the video that Raj made about submassive and massive pulmonary embolism and how to manage these patients on the floors. And you can see here the Wales criteria for DVT, which basically help us to diagnose DVT, because as we said, the signs and symptoms when the patient presents are non-specific. Alright, so let's go over this. Now for the following symptoms, the patient gets 1 point. Alright, so calf swelling more than 3 centimeters compared to the other leg, entire leg swelling, unilateral pitting edema, unilateral swollen superficial veins which are not varicose veins, localized tenderness along the deep veins, history of DVT, cancer which is active cancer or treated cancer in the last 6 months, immobilization of the legs due to cast, paralysis or paresis, and bedridden if the patient is bedridden for 3 or more days. So if the patient has any of the following, they get 1 point for each and every one of them. Now we have here -2 points. -2 points the patient will get if there is an alternative diagnosis, which is not DVT. And how do we interpret now the Wales criteria? Basically, if the patient gets 0 or 1 points, then the DVT is unlikely. Then our next step to confirm that the DVT is not existent, we can obtain D-dimer assay. Now, if you have negative D-dimer, then you don't need any further tests, alright? Because the D-dimer has high sensitivity. And because of SNOUT, basically sensitivity out, highly sensitive test, we will exclude the disease, and in our case, we will exclude the DVT. But the specificity of the D-dimer is low, and since SPIN, this abbreviation, rules in the disease, then positive D-dimer, which has low specificity, doesn't tell you much, so you cannot rule in the DVT. That's why we need here to double check with CT angiography. And also just keep in mind what is D-dimer positivity. Now if the patient is less than 50 years of age, then positive D-dimer is 500 micrograms per milliliter. But if the patient is more than 50 years of age, then what we have to do is multiply the age of the patient by 10. For example, if the patient is 60 years old, then 60 times 10 is 600, then 600 micrograms per milliliter is the normal DD for this patient, alright, the normal D-dimer. So if you want to diagnose the patient with positive D-dimer, this 60-year-old patient has to have D-dimer more than 600. Alright, and if the patient gets 2 or more than 2 points, then the DVT is very likely and we have to perform Doppler ultrasound. And moving on to the Wells criteria for pulmonary embolism. Now here we have +1 point, +1.5 points and +3 points. Now hemoptysis and active cancer get 1 point each. Heart rate more than 100 beats per minute, history of DVT, and if the patient has been bedridden for 3 or more days or the patient has had major surgery in the past 4 weeks, then each of these get 1.5 point. If the patient has clinical signs and symptoms of pulmonary embolism and there is no alternative diagnosis, these two conditions get 3 points. Now, what is the interpretation of this point system? If the patient gets 4 or less than 4 points, then the PE is very unlikely and we can obtain D-dimer assay just for reassurance. But if the patient gathers more than 4 points, then the pulmonary embolism is very likely. Now what we need to do is obtain CT angiography, and remember, CT angiography visualizes better the central pulmonary artery. Alright, and now let's talk about the VQ scan, because they can throw some tricky questions at you on the USMLE STEP exams. Now remember, the VQ scan is a first choice only in the following situations. When you have chronic thromboembolism with pulmonary hypertension class 4, because the VQ scan visualizes better the peripheral pulmonary arteries. Also, it's a first choice during pregnancy, when the patient is allergic to contrast, when the patient has low GFR, or when the patient is obese. In general, only normal or very low probability scans and high probability scans are considered diagnostic. The normal or very low probability VQ scans are associated with up to 6% chance of having pulmonary embolism, whereas the high probability VQ scan is associated with up to 96%, 56 to 96% chance of having pulmonary embolism, and all other scans are considered indeterminate. First, let's discuss some terms here before I show you some very good tables about the management of DVT and PE, which will be more than sufficient for your USMLE STEP exams. Alright, so what is unprovoked DVT? Well, basically DVT for which we cannot find the real cause, right? But on the other hand, provoked DVT can be caused by several things. Now let's see what they are. Now, provoked DVT can be caused by transient major risk factors. And what are these risk factors that are major? Well, major surgery which lasted more than 30 minutes, immobility or hospitalization which has lasted 3 or more than 3 days, and a cesarean section. The transient minor risk factors include minor surgery less than 30 minutes, hospitalization less than 3 days, pregnancy, estrogen therapy, and decreased mobility for 3 or more than 3 days. And we have persistent risk factors that can cause provoked DVT, and they're reversible. Here are cancer, which is curable, and inflammatory bowel disease, which is also curable. And the irreversible persistent risk factors include the inherited thrombophilias that we discussed earlier, chronic heart failure, and metastatic end-stage cancer. Now, quickly to remind ourselves, when someone is on estrogen therapy, and especially when the OCP drugs contain progestin, which is the synthetic version of progesterone, there is an increased risk of DVT. Why? Because estrogen, on the first place, it will increase the clotting factors 2, 7, 10, 12, 13 and fibrinogen, which will increase the risk of developing clots, right, in the deep veins of your legs. And also this progestin, the main effect of progestin is it will increase the lumen of your veins, it will widen your veins, and the blood will start pulling down due to the gravitational pull in your legs, which will also increase the risk of developing DVT because the blood will stay stagnant there and it can start clotting. Now the mainstream of the treatment for pulmonary embolism and deep venous thrombosis is anticoagulation. Now let's discuss first the duration of the anticoagulation therapy, and then we're gonna move on to the choice of anticoagulation therapy. Now you don't have to give any anticoagulation, but you can just monitor with serial Doppler ultrasounds for 2 weeks when you have unprovoked with mild signs and symptoms and no risk factors for progression distal leg DVT. You're going to give anticoagulation for at least 3 months in the following cases: when you have unprovoked with moderate signs and symptoms distal leg DVT, when you have provoked proximal leg DVT or pulmonary embolism, when you have upper extremity proximal DVT, or when you have 2 provoked venous thromboembolism events. If the patient has cancer, you have to give them anticoagulation therapy as long as the cancer is active or being treated, and the preferred anticoagulation therapy here is the low molecular weight heparins. You're going to give the patient long-term anticoagulation therapy with annual re-evaluation in the following 3 cases: when you have unprovoked proximal leg DVT or pulmonary embolism, when you have second unprovoked proximal leg DVT or pulmonary embolism, and when you have chronic thromboembolic pulmonary hypertension. When you treat DVT, you have several options. Now first you have the oral factor Xa inhibitors, the so-called NOAC drugs. Now with the NOAC drugs you can reach therapeutic effect in several hours, so this is great. And the most commonly used one are the rivaroxaban and apixaban. If you're using dabigatran or edoxaban, you have to bridge the treatment with low molecular weight heparin first. Now we have here contraindications to the NOAC drugs, which are board favorite questions, as you know, contraindications to everything. Now remember, do not use the NOAC drugs if the BMI is more than 40 or the creatinine clearance is less than 30. And also remember here the antidotes for the NOAC drugs. Andexanet alpha is the antidote for apixaban, rivaroxaban and edoxaban, which are the direct 10A inhibitors. And idurusizumab is the antidote for dabigatran, which is the direct factor 2 thrombin inhibitor. Now the subcutaneous low molecular weight heparin, you can use it alone or in combination with warfarin simultaneously until you reach INR of 2 to 3. Then you can stop the heparin. And remember, normal INR is 1. And here if you use the low molecular weight heparin, you don't need to monitor the PTT. And contraindications to its use is creatinine clearance less than 30 again. Fondaparinux, which is also subcutaneous, is an alternative to the heparin in patients with heparin-induced thrombocytopenia. And here you don't have to again monitor the PTT, and again contraindication to its use is GFR less than 30. And lastly, you can use unfractionated heparin also here, and here you have to monitor the PTT unfortunately, but the good thing is that it can be used in low GFR, and as you saw before that the contraindications to all of the previous medications is low GFR, but the unfractionated heparin, you can use it in low GFR patients, but also remember that this is the most common cause of HIT, so it has pros and cons of using unfractionated heparin. Now for pulmonary embolism, the best choice is the low molecular weight heparin because it's more efficacious and it causes less heparin-induced thrombocytopenia. For pulmonary embolism, your best choice is actually the low molecular weight heparin. It's more efficacious and it causes less heparin-induced thrombocytopenia. And of course, if you have contraindications to the use of low molecular weight heparin, you can use the unfractionated heparin. Now, something very important that I would like to mention here is that if the patient comes hemodynamically unstable and you're suspecting massive pulmonary embolism, then you have to start this patient immediately on unfractionated heparin IV drip. Why? Because it has very short half-life of 30 minutes. And you can actually stop it abruptly to start thrombolytics if you diagnose massive pulmonary embolism with CT angio, VQ scan or bedside ultrasound. Now, if you diagnose the massive pulmonary embolism, then you have to start the patient on TPA like alteplase and stop heparin and hope that his condition will stabilize once the clot is resolved from the thrombolytics. But more on how to manage the patient on the wards with shock, with massive pulmonary embolism, with dosing and all that, you can check out Roger's video in the internal medicine residency video series. Last but not least, let's discuss the indications for inferior vena cava filter placement. Now we have three situations here. First, if the patient has acute pelvic or proximal leg DVT, you're gonna put vena cava filter if the patient cannot be anticoagulated because of active bleeding, or the patient is at very high risk for bleeding. Now, the second time when you're gonna put the inferior vena cava filter is when the patient is having recurrent leg DVTs despite therapeutic anticoagulation, which is INR 223. And please pay attention here to the word therapeutic anticoagulation, because in the vignette they will describe how the patient is taking heparin or warfarin or whatnot, but the patient has not reached therapeutic anticoagulation yet. So if they haven't reached the therapeutic anticoagulation, you either increase the dose of the current medications, or you keep the same dose but make sure that the patient is actually taking the prescribed medications like the heparins. And if the patient has reached therapeutic anticoagulation and despite that is having recurrent leg DVTs, then you're gonna choose as the right choice inferior vena cava filter. And lastly, you put inferior vena cava filter when you have right ventricular dysfunction with enlarged right ventricle on transthoracic echocardiography, because in this case the next clot, the next pulmonary embolism might kill the patient. And this concludes today's video on DVT and PE. I hope you guys find it useful. I really think that it will help you in your preparation for the USMLE STEP exams, because it gives you structure and everything that you need to know. The most high yield material at least is here in this video. Also, if you want to find out how to manage submassive and massive pulmonary embolism on the floors when you start residency, you can refer to those two videos in our internal medicine residency series playlist. Some of the upcoming videos that we're going to post on our channel will be on topics that have been requested by some of you. And also, please feel free to leave us more comments and more suggestions for videos for topics that you find difficult. Also, don't forget to share our channel on your social media so we can spread the word and the knowledge. Again, good luck, have a super productive day, and see you on the next video.